Okay, so are you ready to go live, sir?
Yes, I'm ready.
Okay, so within the next 5 seconds, we will. So on a 3, 2, 1. So we are live now. We can start our session, sir.
Okay. So yes, good evening to all those who are watching this video. And this is a basically interactive session on overactive bladder. This is a fairly common problem we see in urology practice on a daily basis. So what I have done is basically I plan to give you some information about this disease so that it can be helpful. The presentation has been designed to cater to general public as well as if we get few physicians or urologists to join along with us. So hi everyone. Just to give you a short introduction, I am Dr. Anubhav Raj, and I'm a consultant urologist practicing in Shubham Hospital, Lucknow. And now we'll head straight to the topic, that is overactive bladder. So what is overactive bladder? We'll discuss about it. We'll try to understand the disease, but so that we are basically on equal understanding terms, we'll just have a short definition or know how a few important things which we need to know about. Like urgency, we say that we are having urgency, but how do you define it? So urgency is basically defined as a sudden compelling desire to void, which is difficult to defer. So if you get a desire to void, that is normal, but which has come very suddenly and you're finding it very hard to defer and you get uncomfortable, this feeling is known as urgency. Frequency, voiding too often by day. Normal is considered as less than 8 times per day. So if you're voiding more than 8 times in 24 hours, then this becomes frequency. Nocturia is that you have to wake up in night to urinate during sleep hours. That is, each void has to be preceded and followed by sleep. Many patients come to us and say that before going to sleep, I go to the washroom again and again, but that does not mean that you are having nocturia. Nocturia has to be preceded by sleep and has to be followed by sleep. That is, your sleeping hours are getting disturbed by the need to get up to urinate. What is urgency? Urinary incontinence. Involuntary leakage accompanied by or immediately preceded by urgency. So the patient has an urgency and just he cannot defer this feeling, and before he can reach the washroom, he'll have involuntary leakage of urine. So OAB, that is overactive bladder, we can either call it wet, where the patient is having leak of urine, and the patient may be having urgency but he's able to basically avoid incontinence, that we will be labeling as OAB dry. So now coming to what is it? What is overactive bladder? What are we here to talk about? So overactive bladder is basically a symptom syndrome. That is, it is a clinical basically term given to collection of symptoms which is basically suggestive of some lower urinary tract dysfunction. And to define it, we will define it as basically urgency with or without urge incontinence, usually with frequency and nocturia. So the sine qua non of this disease is that the patient will have urgency and he will have a sudden desire to void and it will become uncomfortable, and the desire to void will be very hard to suppress. This may or may not be associated with incontinence, that is leak of urine, and the patient may also complain of frequency, that is the need to go to the washroom again and again more than 8 times per day. And he may also have nocturia, that is need to get up from sleep in the night during the sleep hours, which is known as nocturia. And the most important thing about overactive bladder is these symptoms should be in the absence of any metabolic or pathological known conditions. So if they are secondary to say urinary tract infection, then they do not constitute overactive bladder. So this is important for basically viewers who are not from the medical field. So this, you can see, this is a healthy and happy bladder. So what are the functions of a healthy and happy bladder is that it should be able to hold in an adult around 300 to 500 ml of urine. It should empty less than 8 times per day. It should be able to hold urine throughout the night so that you need not get up to urinate in the night. And there should be a gradual sensation of filling, and when the filling is complete, that is, say the functional bladder capacity is around 400 to 500 ml, then you should get an urge to void, but which should be suppressible. Whereas this is the unhappy bladder, overactive bladder, you may call it. So what are its characteristics? It basically empties more than 8 times per day, that is, the patient is having frequency. More than 2 times per night, that is, the patient is having nocturia. And it should have a symptom which is the sine qua non, that is urgency, which is a sudden compelling desire to void, and that is difficult to differ. So this is the basic difference between a healthy bladder versus an overactive bladder. And so what is mixed urinary incontinence? We have already seen that urgency incontinence is when the patient has a feeling of urgency, and before he reaches the washroom, he has an involuntary leak of urine. This is known as urgency urinary incontinence. Another common type of incontinence, especially in females, is stress urinary incontinence. That is, when there is rise in the intra-abdominal pressure, especially on maneuvers like coughing, sneezing, straining, getting up from a squatting position, or going down into the squatting position. That is stress urinary incontinence. And a symptom complex where you have both type of incontinence, that is, the patient has stress urinary incontinence as well as urgency urinary incontinence. This becomes, or this is known as a mixed urinary incontinence. Another symptom complex which we find commonly in our patients after we have ruled out infection and other metabolic and pathological conditions is bladder pain syndrome. So what happens in bladder pain syndrome? Basically, the patient has a painful sensation of filling of his or her bladder. So whereas in overactive bladder, pain is not a typically component of OAB. So bladder pain syndrome is defined as basically a complaint of suprapubic pain, that is lower abdomen for basically layperson. So it is defined as a complaint of suprapubic pain related to bladder filling, which may be associated with increased daytime and nighttime frequency in the absence of proven infection or other pathology. So it has few traits which are common to overactive bladder, that is frequency and nocturia. But only thing is that it is basically a complaint of suprapubic pain which is related to bladder filling. So in this diagram, you can see this will make it a little clear. BPS stands for bladder pain syndrome. The patient may have predominantly pain. He may have frequency and nocturia, and few patients may also have urgency. Whereas in overactive bladder, the main criteria is urgency. Patient may have urgency urinary incontinence and he or she may have frequency, but usually pain is not associated with OAB. This is a diagram to basically get you to understand what happens in OAB. So this is a normal sensation, like as the time increases, the urine production is filling our bladder. So the degree of sensation should rise like this, gradual. As the bladder is filling, we are getting to know that yes, we are having a sensation of urine, and this sensation is gradually voiding. And when it reaches a peak, then, and if we are in a basically comfortable setting and apt setting, then we'll be able to go to the washroom and relieve us of this sensation. Whereas in overactive bladder, this is the bladder filling, and suddenly we'll have a basically sudden compelling desire to void. So this is known as the urgency. That is, there is a sudden discomforting sensation that you need to urinate right now. So, what is the burden of disease in India? Actually, in India, there has been no prevalence and incidence studies, but various Western studies have been done, which have found the prevalence of around 12 to 17% in entire population. So, this is a huge number. You can imagine 100 people randomly. You pick up 100 people, and out of those, at least 15 to 20 of them will be having symptoms which can be attributed to OAB. Prevalence increases with increasing age, more so in males, and urgency incontinence is more prevalent in females. So this will help you. This is basically, these are the two last studies which have been done, C4 study and the APEX study. Both have shown that as the age increases, as we go from 40 years to 65 years, you can see the prevalence as is increasing. It starts from around 10% or 5% in around third and fourth decade, and it increases till 30 to 35% as we go to the sixth and seventh decade. So the burden of this disease is huge. In basically our urology OPDs, daily we see cases, at least 20% of our patients are basically having symptoms of OAB. You can see the difference between OAB in women and OAB in men. So women with OAB usually have urgency urinary incontinence. 55% of the female patients will have incontinence. This is a very common problem in our Indian setup also. And because what the patients attribute this is to old age. So the many patients come, they are suffering for the last many years, but they just say that they thought that this was because of old age, and they try to defer seeking treatment. In men, the symptoms are there. So we have an almost equivalent prevalence, but the urgency urinary incontinence is a little less. So only 16% of men with overactive bladder present with urgency urinary incontinence. So you can see that this is basically, this has no geographical limitation. In all the Western countries, Eastern countries, Western, Central Europe, all countries have done their prevalence studies, and almost all countries show that male and female predominance is from basically 10 to 22%. So the burden of this disease is huge. And you can see like what is the proportion of women who are seeking consultation for basically pelvic floor disorders. They're having some discomfort regarding their basically pelvic organs, like they may be having some problem in urination, some problem in defecation. So the prevalence is around basically from 50 to 80% of patients who are seeking basically attention for pelvic floor disorders. Most of them also have symptoms of OAB. So now we have basically understood what is OAB. Many of us, many of general public is suffering from these symptoms. We think that this is just like, I feel the urge to urinate a lot, this is normal, but this is not normal. This is a disease which is known as overactive bladder, and it has a tremendous impact on the quality of life of the patient. So you can imagine the basically like this the areas of life where this has an impact is huge. So the patient may have physical basically decrease in quality of life. So the patient may have limitation of cessation of physical activities. The thought of going for regular exercises, regular jogging, or basically even playing with your children, this can be hampered if you're suffering from overactive bladder. You try to avoid going outside, because suppose what will happen if you have a little urinary incontinence, so you will be in a difficult situation. You'll have to look for basically basically restroom to change your clothes or put on a pad. So you have physical limitations. Psychologically, the patient feel guilt, depression, they lose their self-respect and dignity, and they are left with these symptoms, and it's not a very good basically situation for them. They fear that they are being becoming a burden for the family. They are not going outside, and they are sticking to themselves, and they are basically they lose self-respect, that there's a lack of bladder control, the smell of urine which has leaked, it makes them just diffident, and they go into apathy and denial, and they think that this is my life and I have been cursed with these things. But timely seeking treatment for this can all make it correct. So what is the social aspects of this disease? So there's a reduction in social interaction. People try to avoid going out with their friends, going out to meet their friends. They don't even invite them to their own house. And there's change in alteration of travel plans to try to avoid, like, I'll not travel via train because 8 hours I cannot sit in a basically berth in the railway with other people around. What will happen if I get an episode of incontinence, or what will people think if I go to the restroom again and again? So there's basically increased risk of institutionalization, because sometimes the basically children also do not understand this problem, and they think that their old age parents have become a burden, and then they try to send them to an institution. And domestically, what will happen is that you'll be having requirements of specialized clothing, you'll need paddings, so it will all cost, basically add on cost to the daily expenditure of the household. And occupationally, the patient may have absence from work, there is decreased productivity, and basically because of basically the lack of confidence and basically absence from work, this will decrease the productivity. Even sexual activities also can be basically become a burden for these patients, because they try to avoid intimacy because they think that the smell of urine, or suppose if I get urgency before or after sexual activity. So these all things, you can just imagine what a tremendous burden these things become on the mind of the patient. So, and it's the situation is this, like you can see, what we see is just the tip of the iceberg. Actually the burden is huge. 15 to 20% of the population is a huge number. There's no other disease which affects at least 15 to 20% of a entire population. So you just have to understand, like, few patients are having less symptoms, but few patients are also suffering with more symptoms. So we need to basically be aware of these symptoms and seek treatment in a timely manner. So why is basically it is under reported? So only less than half the patient with bladder control problems reported to their healthcare provider. But why? What is the reason? So the reason, it has been seen, or in retrospect we have just come to the conclusion that it is because of embarrassment, low expectation for therapy. People think that what good a medicine will do. I've been born with these symptoms, like my bladder is weak, I go to urination a lot, it's not a big deal, and I have to live with these symptoms. And also the thought that this is a normal part of aging, ki I am getting old, so ab ye to hona hi hai. So these things, these thoughts prevent people from reporting it to their healthcare providers. Also because like there is availability of pads and absorbent products. So what this does is, like, people have their accessibility to these things, and so they resort to these things rather than seeking treatment from a physician. So these are the factors which basically delay treatment. So, like what we have already discussed, that patients suffer needlessly from overactive bladder. So the overactive bladder negatively impacts quality of life. It has an adverse effect on the emotional well-being of the patient, social relationships, productivity goes down because of absence from work, physical functioning is decreased, it relates to unnecessary anxiety, depression, mood disorders. People avoid activities like travel, and daily activities which give pleasure to you, like travel, interaction with your children. So these are also getting hampered, and then the patients irreversibly go into anxiety and depression and these disorders. So like we have already discussed this, that there is fear of embarrassment and misconceptions which we have talked about. And so these things basically make the patient needlessly suffer from overactive bladder. So another study was done just to evaluate like what should be the ideal approach. Should the healthcare provider initiate discussion about these symptoms? Should this be a part of a normal history taking of a like every patient we examine? So actually you can see is like total of suppose 1,000 patients which were basically interviewed. 37% of these patients said that they would be comfortable if the healthcare provider brought up the topic. So this is again something which we as healthcare providers, or especially if we are dealing with patients who have uh, symptoms attributable to pelvic floor disorders, so we should be the first to ask them about these things, like are you having urgency, are you having some problem with your urination, or are you totally satisfied and don't have a basically problem? So I think the healthcare providers should include the history of these symptoms as a general history taking for almost all patients, especially if they are in their third, fourth, and fifth decade of life. So now this is mainly for the medical professionals who have joined us. So the pathophysiology is like what causes this disease. So why is it a patient has overactive bladder and the another person is not having overactive bladder? What is the cause of this? So actually there is no pinpoint cause. There is no single cause which can be attributable. So there are many hypotheses, many studies have been done. So it is basically a multifactorial and multi-layered across all levels of neural control. So the control is like the brain, then spinal cords. There are many circuits or basically neurons, synapses running through the spinal cord, and we have the urothelium, that is the inner lining of the bladder, and we have the detrusor muscle, that is the muscle of the bladder. So there have been theory which says that there is some problem in the neural control. There are some theories which say that we have some problem in basically the urothelium. It becomes more sensory, it becomes more excitable, and there are some theories that say that it is because of the detrusor muscle. It becomes overactive like without sensation, or it becomes autonomic from the suppression by the brain, and it initiates the contractions on itself. So we have basically sensory theory, and we have the motor theory, and we have the neural theory. So actually it is a basically multifactorial and multi-layered across all these three things. So you can see that we have basically neural integration, like the many parts of the brain are involved. There is basically afferent conscious awareness, so this brings the sensory, and then we have the efferent, that is the muscles involved. So a disbalance between all these things will lead to a contraction which is uncalled for. So how do you diagnose overactive bladder for patients? This is a good thing for you that it is not a invasive test. It's just a simple art of history taking, which your urologist will ask you few questions. He'll try to rule out few things, and then he can start the simple treatment for overactive bladder. So most cases of overactive bladder can be diagnosed based on patient history, symptom assessment, physical examination, and urine analysis. That is, you just give a small quantity of urine for examination, infections are ruled out, and if your history and your basically symptoms are corroborating with overactive bladder, then your treatment can be started. So initiation of non-invasive treatment does not require an extensive further workup. So a single visit to your urologist can be helpful, does not even involve multiple visits and all. So what you need to do is visit your urologist at the basically earliest, and he should give you time and try to understand your symptoms. So what questions will be asked to the patient is basically how long are you having this? What was your age when this started? What is the amount of urine you void in each time you go? Or if there is leakage, what is the amount of leak you have? And is it related to any activity? and what number of pads do you have to use, and if the urgency, how much is the urgency, whether you have stress urinary incontinence, and other things like what is your daily fluid intake, have you had any history of UTIs, what are you having any pain, blood in the urine, and few simple examination and your medication history. Examination is also not very basically, it's also a short examination, just the examination of the abdomen will be done to see if the bladder is full, then the external genitalia to look at the basically like the condition of the vagina, if there is a prolapse you need to rule out the uterine prolapse, any malignancy, tone of the rectum to basically this is the quick way of assessing any neurological basically deficits. So after you have done a quick assessment, so this is how you do symptom assessment to differentiate from basically other types of incontinence, examination to exclude any prolapse of the pelvic organs, a simple test that is urine analysis to rule out infections, and only in special circumstances other tests like cystoscopy, ultrasound of the abdomen, and urodynamic assessment is required. Otherwise the medication can be started on simple history examination and urine analysis. So guidelines are there which suggest that the clinician should engage in a diagnostic basically process to characterize the overactive bladder. Minimum requirements are a careful history physical examination, and in some patients urine culture and post-word residue volume can be basically performed. Special tests like urodynamics, cystoscopy, ultrasounds, they are not to be used in initial workup of an uncomplicated patient. So these are some comorbidities, that is the patient with these afflictions are more likely to have OAB. So you need to rule out vulvovaginitis, skin infection, depression, urinary tract infections, patients with history of falls and fractures. In these subset of patients, you need to be alert that they are more prone for getting symptoms of overactive bladder. This is a basically chart of urodynamic study. So what is urodynamic? Very simple to understand. Urodynamic is just a pressure transducer which is placed in the urinary bladder via a small catheter or tube. So what it does is basically it records the pressure of the bladder. So as you can see, bladder should be stable and it should contract just before urination. But in this case, you can see it has contractions, pressures up spiking even before the urination has started, and these pressures are associated with leak and precipitated voiding. So this is just for documentation, or if an invasive process is being done or the patient has failed the first two lines of treatment, then we order such tests. So coming to management, so what are the treatment goals for overactive bladder? Treatment goals are fairly simple and they need to be defined so that your patient can basically get the maximum benefit from the therapy. So first is to eliminate or improve urgency urinary incontinence. Most basically debilitating factor for the patient is incontinence. So that is the most important thing which need to be eliminated or improved. Second is you need to reduce the urgency and frequency and nocturia or incontinence. Then there should be improvement in warning time. Like the patient should not have a sudden compelling desire to void. The desire to void should come a little gradually so that the patient has the time to place himself in an appropriate place, and so that if he gets the urge, then he'll be able to void. And these things are important, but one thing which is even more important is that treatment should be designed such that the patient is compliant to it. Like we cannot write 5 medicines and think that the patient will keep on taking them for months and year on. So what we need to do is put the patient on less medicines and basically teach him things which are sustainable, like exercises, dietary changes which the patient can himself do. And you need to discuss with the patient like what are his expectations, and tailor your treatment according to it. So we have many lines of treatment, or many lines of attack, you can call them. So first is we need to assess the bother and the precipitating factors. We also need to do is basically give him a bladder diary or chart, so that just before we start our treatment, we have a documentation of the number of episodes of leak, number of times the patient is having urgency, and the frequency, that is the number of times the patient is having to get up to urinate in the day as well as night. And then the first line is a conservative therapy, where the patient is taught about basically fluid intake, his fluid habits, his dietary changes are done, behavioral changes, bladder training is started. Second line is pharmacotherapy, that is treatment by drugs. And the third line is basically botulinum toxin, which is a basically muscle relaxant, which is injected into the urinary bladder, and neuromodulation. Fourth line is the last line, when nothing has worked and the patient is having basically decrease in his quality of life and significant bother. Then we can even do a bladder augmentation or a removal of the bladder, which is known as the cystectomy surgery. So what are the conservative approaches? This is first line of treatment, and it involves basically lifestyle modifications, which include basically fluid management, like the amount of fluid you drink, where do you drink it, at what time do you drink it. And so that suppose the patient is having urgency episodes more in the afternoon, so what we will try, and he's in his workplace, so what we try to do is decrease the fluid during those hours. And then as he reaches his home, then we can ask him that now you can have your liquids as usual, so that the overall 24 hours fluid is around 2 to 3 liters. Caffeine reduction is done, dietary changes are advised. We basically ask the patient to avoid foods which will cause constipation, or which are basically high in, because and all, they can cause basically overactivity. We ask the patient actively basically aim for weight loss, because as you basically, if the muscles and the body is healthy, so the pelvic floor muscles and all are also healthy, so it has a tremendous effect on basically the way you void and this overactive bladder. Second is like pelvic muscle rehabilitation. How do we do it? So there are some exercises which the patient can be taught. We ask the patient to do self-monitoring. So working with this first part, that's lifestyle modification, is a basically self-monitoring, which will give a positive feedback to the patient. So if he sees that from the day I have reduced my caffeine intake, so the number of voids has decreased. So it becomes basically a self-monitoring and gives a positive feedback to the patient, and the healthy habits are encouraged in this way. So we can schedule voiding, like ask the patient to go 2 hourly or 3 hourly, so that the bladder is empty most of the time, and he is not getting that urge to void in a place where he will become uncomfortable. We teach the patient to delay voiding. We given basically like a simple counting method can be done, like where the patient counts 1 2 3 and tries to delay the his going to the restroom. So what happens is, like, this is just like a training, so maybe first few times he can hold only 1 2 3 and then he'll need to go. But as the days go on, like maybe his count increases to 10 20 30, and then one day will come when he'll be able to defer his voiding, and he'll become basically more settled in his like workplace and social area also. Double voiding is like go for urination, then 15 minutes later again go and void, so that the bladder is completely empty and you don't get basically unscheduled basically urges. Exercises again, then pelvic floor relaxation, urge strategies, urge control techniques. uh, Biofeedback is like you need to contract your pelvic muscles and feel that yes, you've contracted the muscles. So these pelvic exercises have helped the patients in getting control over their urinary frequency and urgency. Pharmacotherapy is basically the drug management. It is basically, we have two types of drugs. Mainstay is basically anticholinergic or anti-muscarinic agents. These are like almost used in 90% of the patients. And the other class of drugs is basically non-anticholinergic agents, out of which basically this Mirabegron is a newer drug, and basically other are more or less in a clinical trial setting. So, like you can see, drugs basically they started appearing in 1970s. We started with flevoxate, then oxybutynin and other drugs, and now we have newer anticholinergics which are more selective for M3 antimuscarinics, and basically they have fewer side effects and they are more specific in controlling urinary tract infection. So basically, what kind of receptors we have in the urinary bladder? There are 5 types of receptors, but M3 receptors are responsible for parasympathetic detrusor contraction. So drugs which block these receptors, they will be a muscle relaxing effect, and they will be basically decreased in frequency. So again, we have these mechanisms. Let's not go into much details in this, but you can see like most of the drugs have now been basically tailored so that they have to be taken either once daily or maximum twice daily. So these drugs have also been developed such that it does not become a problem for the patient to take them. Almost all drugs which we use now for overactive bladder are a single daily dose to the patient. But they have anticholinergic drugs have few side effects, that these are class related side effects and they are hard to avoid. So most of the patients will have dry mouth, constipation. The patient may have basically urinary retention, increase in urinary tract infection, blurred vision, headaches, dry eyes. These are side effects. Few patients will have them, few may be able to tolerate them better. They are seen, few basically effects are seen with one agent, few other type of side effects are seen with other agent. So because of these basically side effects, so there was always a basically thought of getting a new drug which will basically uh, help the patient in avoiding these symptoms. So in the 1970s, there was another drug known as Mirabegron, which is a beta 3 basically adrenergic receptor agonist, and it has a different mechanism from anticholinergics, and has a very good side effect profile, and the patients are able to tolerate it much better. So it causes basically direct relaxation of the bladder muscles, and basically it inhibits spontaneous contractility of the bladder, and also it has inhibition of bladder sensory activity. So it helps in improving the bladder capacity without impeding bladder volume. So many studies were done, and basically it showed basically good improvement, significant improvement in incontinence episodes and number of voids per 24 hours, with a significantly better side effect profile. So like we can see, many studies were done. What was done was combination of basically Mirabegron and Solifenacin. Mirabegron is the newer drug, Solifenacin is like the typical anti-muscarinic, and a combination of them showed that they have even better response than either drug alone. So symphony and synergy studies were done. So many kind of studies were done, and so now we have more or less we have two main drugs. Like first is anti-muscarinic. We have many different anti-muscarinics. Few patients do not respond to one, they may respond to other. Few patients may have side effects with one, maybe they'll not have side effects with other. So we have at least 5 to 7 drugs which we can try and see which drug suits the patient the most. And if the patients are not able to tolerate anticholinergics because of dry mouth, constipation, headache, or blurring of vision, then we can switch to basically beta 3 against Mirabegron, which is a good drug. It has a slower onset of action, but in the end, the patients are satisfied because of the less side effect profile. Third line is like tibial nerve stimulation, sacral nerve stimulation. Botulinum toxin can be injected into the bladder muscle, and it has basically effect of 60 to 80%. Only thing is that these basically therapies are not permanent. So what will happen is it will have an effect which will last for around 1 year, and then again the patient will start developing complaints. So this is not sustainable in the long term. So like you can see sacral neuromodulation associated with 5-year success rate of around 60%, and drawbacks like include almost definitive revision which will be required after 5 years, and undesirable pain and stimulation. So this is how sacral nerve stimulation is done. Electrode is implanted into the sacral nerves in the back, and you have an external control box. It gives continuous stimulation to the sacral nerve, which overall inhibits the sensory nerves to the urinary bladder. So somehow it resets the circuits of the urinary bladder and prevent the patient from getting unnecessary urges. And so this is how botulinum toxin is injected. We go into the urinary bladder with an endoscope and inject botulinum toxin as at basically pre-selected points in the urinary bladder. Botulinum toxin is a muscle relaxant, so it relaxes the bladder and prevents basically undue contractions of the bladder. Fourth line is basically rarely required, but if the patient has not responded to above 3 lines and he wants that like you need to do something about it, then we can do augmentation cystoplasty, that is interposing a segment of the intestine in the bladder so that its capacity is increased and its coordinated contractions are decreased. Urinary diversion can be done, and basically removal of the urinary bladder can be done. So this is very, very rarely done because of effective pharmacotherapy now, and basically pros and cons need to be weighed for individual cases. So what is the take-home message is that overactive bladder is much more common than you expect. Being a urologist, I get to see like every fifth of a patient is having overactive symptoms. So this forms a chunk of our clinical practice, and what we need to be doing as physicians is that we need to be more aware, sensate, and basically we should be the first to initiate discussion about these symptoms, and they should be done in a manner which does not make the patient uncomfortable. So we need to address this for each of our patient. Maybe he is or she is suffering from these symptoms, and we need to understand, set target therapies, counsel the patient, start with behavioral changes, muscle exercises, dietary modifications, and then if the patient or the bother is significant, then we can start pharmacotherapy. Pharmacotherapy is also quite effective, and if you have basically explained the side effects to the patient, it is tolerable, and the patients usually respond very well, and they can have basically their life-changing experience with these drugs. So it is not very well understood by clinicians. I have not seen basically general physicians, or even in my days as a general surgeon, I also did not understand what is overactive bladder, or I did not ever give it any importance. But now practicing as a urologist for the last 5 years, I've got to basically understand like this is an immense burden, and this affects the quality of life from for people, especially like the female patients who are too embarrassed to bring up these things, and they are suffering, needlessly suffering from these symptoms. Patients are usually suffering silently. A careful history and examination should be done to basically draw a management plan, and then basically we need to look after our patients well. So this was basically about overactive bladder. Those who are not from the medical field, so for you the message is like, if you are having symptoms of basically urgency, that is you get when you get the urge to void, it is quite difficult to differ. or basically if you need to go to the washroom much more frequently as compared to your colleagues, or as compared to other students, or as compared to your friends, then you might be having overactive bladder. So a short visit to your urologist will not hurt. You just need to share your symptoms. It's not like you will be given 5 to 10 medication, a number of invasive tests. You just need to get your symptoms assessed. Maybe just a small piece of advice will go a long way in helping you out of these problems. Okay, thank you.
So we have few questions in the chat box, sir.
Sure, I'll just go through them. So yes, our first question is like, what are some early signs of overactive bladder? So like what I've already told you, early signs, the main symptom is urgency. Everyone gets the urge to void, so but we can suppress it. We know that like we have another half hour to go, then maybe it will become an urgency for us to go and void. But patients of overactive bladder get this urgency within seconds. So they are sitting normally, working on their laptops, doing some activity, cooking the food. Suddenly they need to set aside their work. Important thing, they'll have to leave the class or leave the meeting, and they'll have to take a washroom break. So this is the earliest symptom the patient may have. Few patients do not have urgency, they can suppress it, but the number of times they go for urination is quite a lot. They say that I have to go every half an hour, every 1 hour. So I think frequency and urgency, these are the earliest sign of overactive bladder. Another question which has come up is basically like how pelvic floor exercises help in urine leakage. So like pelvic floor exercises, what is does is basically like I have told you, the bladder control is via three kind of pathways. One is coming from the brain via the spinal cord, and then there are nerves which make the bladder silent also, and they also ask the bladder to contract when the time is right. So pelvic floor exercises gives a basically positive feedback, or it somehow like calms the electrical circuits around the basically electrical circuits of the urinary bladder, so that the like the voiding becomes normal again. So it is just like a biofeedback for the urinary bladder, and it helps in that way. And also the strength of the pelvic muscle, if they are regained, so when the patient gets the urge to void, he'll be in a better position to control his urine. Another question is like, is it really caffeine intake which increases urinary frequency or leakage? So actually, there were studies done where many type of dietary changes were studied in patients. We had two subsets of patient. One was basically given caffeine rich diet. Another patient was given caffeine curtailed diet. And then it was basically compared which group of patient had basically more number of urgency, more number of incontinence episodes. So it was found that caffeine intake is basically significantly associated with increased number of urgency and urgency incontinence episodes. That is why it has been basically established as a general like guideline for us to ask the patient to decrease his caffeine intake. Another question which has come up is like, doctor, I'm working in a government hospital in Uttarakhand as a junior assistant doctor. So for bedwetting, what should I prescribe? Imipramine or desmopressin? Like this we need to take a little more seriously. If a patient is having bedwetting, then first and foremost you need to rule out many other things. Bedwetting is not same as overactive bladder. Bedwetting can be either primarily nocturnal enuresis or it could be secondary to some other cause. So what it, like a pediatric patient, 5-year-old, 6-year-old child who is bedwetting, this is normal. After 10 years, only 5 to 10% of children have bedwetting, and after 15 years, only 1% of children will be bedwetting. But if you think that he's also having secondary symptoms like obstructive urinary symptoms, irritative urinary symptoms, fever, recurrent UTIs, then this could be a secondary urinary enuresis. So you need to do the test like urine analysis, urine culture, ultrasounds, post-voidus due, and uroflow estimation. So it cannot be prescribed in a single way like imipramine or desmopressin. What we do is basically, if we have established that the child is suffering from primary nocturnal enuresis, we start with basically antidiuretic hormone, that is desmopressin, and it comes with a brand name from Minrin, and which is quite helpful and has less side effects. But suppose like this is a personal preference for us. Whereas if the patient is not has behavioral problems as well, then imipramine can also be prescribed, or first and foremost alarm voiding and basically good urinary habits can be inculcated into the child. So these were the few questions we had, and I hope you had a you got few points, few key take home points. So for both the physicians and like the general public who are connected to us. And this is, you just need to be a little aware about this disease. We should be having more of talks and seminars on overactive bladder. General public awareness should be increased on overactive bladder, because it will help us in basically being sensitive to patients who are having these symptoms, and not take it very lightly or in a jestful manner. I'm thankful for basically like being given this opportunity to talk to you about this common problem which is known as overactive bladder. Thank you.
So thank you so much, sir, to enlightening us on this wonderful topic. So let us wait for some more time. If our delegates have any more questions or queries, then they will ask.
Okay, no problem.
So we have one more question which I have posted in the chat box, sir.
Okay. Yes, another question which has just come up is like, if a child is having the feeling of urinating just after drinking water, is this a sign of overactive bladder? So not exactly. So like, it is not related to a time frame. What is the symptom of overactive bladder is basically a sudden dip, a sudden urge to void. If the void comes after drinking a lot of water, if you're going to like the washroom 3 times in half an hour, this does not constitute overactive bladder. If you are in a apt position, you're in your bedroom, you're in your house, you are drinking a lot of water, you're staying indoors in air conditioned room, and you need to get up 2 times 3 times in a short time to urinate, this is not a sign of overactive bladder. Overactive bladder is when these symptoms persist for days on end, like you, this becomes a habit, like you need to go every half an hour to void, or the feeling of urination comes so suddenly and so inappropriately, then that it makes you uncomfortable. So this becomes overactive bladder. If the child is having a feeling of urinating just drinking after water, it does not constitute overactive bladder. So many times it becomes behavioral changes in the child. So we need to address this, train the child a little better, ask him to try to defer his going to the washroom, talk to the child, assess the feeling he's having, like whether this is a painful feeling or is he finding it hard to defer urination. But as such, this does not constitute a symptom of overactive bladder.
So thank you so much, sir. So as of now, we have no more queries from the delegate side. So should we wait for 1 minute more, or should we conclude the session?
I think we can wait 1 minute more, then we'll conclude it.
Okay. Okay, sir.
So the problem more is with basically the female and the elderly patient. Like their caretakers, their children, they also think that this is because of old age and this is a part of the aging process. And they are also reluctant to bring their parents or the old people to us for basically treatment. They just think that this is part of old age. He is going for the urination maybe 10-20 times a day. This happens, he's already taking so much medicine. What will the doctor do? He'll add another medicine. So these things basically prevent especially the old age elderly people and especially the female subset of patients from getting proper treatment. So I just hope that talks like this will basically increase the awareness of this and help people in identifying these symptoms and basically getting their near and dear ones for a consultation so that they can be managed in a better way and their life becomes basically of a better quality.
So thank you so much, sir. So till now we have no more questions or queries. So should we conclude the session, sir, with your permission?
Yes, definitely.
Okay, thank you, sir. On the behalf of the organizer, I would like to thank you for your insightful and such an informative talk. Sir, with this, I'm ending the session now. Thank you, sir. Thank you so much.
Thanks a lot. Okay, bye. Take care.